I'm happy to be with you, and I would like to thank Chip for inviting me to speak about is DADA2 associated with lymphoma? So definitely the disease is underdiagnosed. So I diagnosed these two patients in 2016, and I just diagnosed two monozygotic twins a month ago. So these two brothers with DADA2 who presented with Hodgkin lymphoma, and the question is DADA2 associated with lymphoma? And my question to you, who should treat patient with DADA2? So is it the immunologist, hematologist, or rheumatologist? So we may discuss this one in the lunch break. So the first patient who was 5 years old, he presented with hepatosplenomegaly, and he was sent for investigation. And he's a third child of first degree Saudi parents. And when he presented, he was otherwise well. And his growth parameter was on the 5th centile. And this is his lab work. And it was normal, but retrospectively, if you look at it here, you can see he was having lymphopenia and the hemoglobin was low. The platelet was normal, and the other investigations, and including the viral serology was negative. So during follow-up, a few months later, he developed non-tender cervical lymph node enlargement, and the serology was, the viral serology was negative. And histopathological examination of the excisional lymph node showed Hodgkin lymphoma, which is mixed-cellulated type, with no other feature other than the Hodgkin lymphoma. As you can see here, this is the histopathological slide, and it's showing on the left side the Stierberg read cells, as you can see it here, and it's confirmed on the CD30 immunophenotyping. It's multi-nucleated cells, and it's sometimes they call it popcorn cell. So the workup for the Hodgkin lymphoma for staging showed that he's stage 3B, and the bone marrow was negative on both sides. So he was started on the protocol, including the chemotherapy, dexamethasone, bleomycin, vincristine, etoposide, prednisolone, and cyclophosphamide. And the reevaluation, as usual, after 2 cycles of chemotherapy, revealed that he's a slow early response. So his chemotherapy was upgraded to dexamethasone, etoposide, cisplatin, and cytarabine, to complete a total of 6 cycles. And in addition to that, he received radiation therapy. So his course was complicated by multiple febrile neutropenia infections, and also a chronic recurrent chest infection. So 3 months after finishing his chemotherapy and the course of treatment of Hodgkin lymphoma, he continued to have persistent splenomegaly, and also cytopenia, mainly involving the RBC, where he required multiple transfusion for that. And the malignancy was excluded by bone marrow study and also by PET scan. And the result also of the PCR and the inherited bone marrow failure panel came to be negative. So empirically, he was treated with prednisolone, 2 milligram per kg per day, and in about 6 weeks, he started to show regression of the splenomegaly, and he was off transfusion. So with the follow-up, we couldn't wean him from the steroid, and he remained on small dose of 0.5 milligram per kg every other day. And his condition was complicated by recurrent infection after finishing the Hodgkin lymphoma treatment in the form of chest infection, cellulitis, and skin abscess around the aortic cath, which required intravenous antibiotic. So we thought to check his immunological status, and which revealed hypogammaglobulinemia. As you can see here, his IgG is low and his IgA is low. The IgM was normal. So the whole exome analysis was sent for him at that time, which revealed a homozygous variant, an ADA gene with new mutation in the truncated gene. So that one was the first time for me to hear about the disease, the ADA2 mutation. And I would like to thank Dr. Isabel Mates and also Mike Hirschfield. They helped me to send for and to look at the case. So we sent the assay for ADA2 enzyme, and which revealed undetectable ADA level. Also, we did a brain MRI, and we didn't show any vasculopathy. So he remained stable on small dose of prednisone and IVIG, and also prophylaxis for PCB. But for the last 18 months, he started to have again cytopenia, which is requiring multiple transfusion for the blood, for the RBC and the platelet, and also together with the failure to thrive and chronic lung disease. So after the confirmation, we start him in anti-TNF, 5 milligram per kg per week, and after a few months, he didn't show any response. So now he's in sirolimus and steroid for the last 6 weeks and showing good response. He's off blood transfusion. So this is his brother. So his brother is 9 months after the diagnosis of the first one. He presented with hepatosplenomegaly and generalized lymphadenopathy. His lymph node biopsy revealed the diagnosis of classical Hodgkin lymphoma, the lymphocyte-rich subtype, which is different from the initial his brother. And he was staged as a milder case, 3A, Hodgkin lymphoma, and he responded to the chemotherapy. He was given for 4 cycles, and he showed a rapid early response. So similar to his sibling, the whole exome showed the same mutation in the ADA gene. And it was also confirmed by the ADA enzyme, which was undetectable. And he was screened for immunoglobulin level, which showed hypogammaglobulinemia, and he remained stable in remission, and he's not on any treatment now. As you can see here, the same on the initial presentation, showing here there was leukopenia and lymphopenia, and also neutropenia on presentation with Hodgkin lymphoma. And here the immunoglobulins showed that it is low in the IgM and in the IgA, and also in the IgEG. So this is the histopathological examination for the second patient, which showing the same with the immune staining of the CD30, showing the Sternberg read cells. So our cases are actually interesting for several reasons. So the first is what we are presenting a novel mutation in DADA, causing DADA2. And more importantly, this is the first detailed description of Hodgkin lymphoma in DADA2. And as you know, with the lymphoproliferation is an important phenotype in DADA2, and also the previous note of a single case of Hodgkin lymphoma and DADA2, and also the T cell large granular leukemia. So we think that it is the link between DADA2 and Hodgkin lymphoma is likely to be causative. And given together with the West analysis and the previous inherited bone marrow failure panel, failed actually to see any childhood cancer related to that. So we think it's important, I mean, to see with the familial Hodgkin lymphoma, and if they present with unusual presentation, that you have to think about data to diagnose it early to have genetic counseling and optimum treatment. Thank you.